geriatric assessments, and we actually have a special guest with us here too to help us kind of walk through this. I'll give her an opportunity to introduce herself. She's not Sue Hazlett, as her title suggests there. Sue, I know Sue's here too, but
I'm here.
No, I was just asking your mom to introduce herself.
Okay. Sue Hazlett, project manager.
And your mom.
Nancy, do you want to introduce yourself?
Sure. I'm Nancy Brown. I'm your whatever victim of the day, maybe. I'm the old lady.
Okay. And how would you like us to refer to you?
Nancy is fine.
Great, thanks. Thank you for your time today, Nancy.
You're
Yeah, so Nancy is going to be, as she said, our victim. So just as we talk through the different components of the geriatric assessment, I thought it just is, more useful and helpful to actually hear then how that conversation can take place, and actually hear from an older adult as well. So what is, well, this is our objectives today, which you can see there. And I think everybody has access to these slides as well, right, Denise?
They will receive them afterwards.
Okay. And to use the example of Mrs. Smith here, she's 78 years old. She has COPD, cardiovascular disease, and has had cardiac stents, high blood pressure, urinary incontinence, and osteoarthritis. And she worked as a machinist at a local factory until she retired at the age of 65, and she smoked for 30 years. So everyone just kind of, you can close your eyes actually if you want, or just kind of imagine in your head, like, what does Mrs. Smith look like to you? Who do you picture? She got chronic illnesses. She had a manual labor job. She worked hard. She smoked. So do you think this is Mrs. Smith? Get some thumbs up or raise the hands if this is kind of what you were picturing. I see a couple nods, a couple head bobs, thumbs up. Or how about this? Is this Mrs. Smith? Is this what anybody pictured? A few, but not quite as many. And you're right. Many of us, when we think about older adults, especially when we start thinking about those who have chronic illnesses, I think a lot of us are going to pick, or the picture that might come into our head is Mrs. Smith here on the left. When in actuality, when we talk about older adults especially, a list of diagnoses, a list of medications, past medical history, none of those things actually give us a really good sense of who Mrs. Smith is and what she's still capable of accomplishing. And that's actually part of why we go through the comprehensive geriatric assessment, because regardless if she's on the left or on the right, this person is someone that we can continue to optimize their health. So there are changes that occur as we get older, and this is probably a list that you've seen already in some of the other videos, but each of our body systems does change, and we have less homeostasis. So we have less the ability to balance, maintaining our function with the insults that occur to our body every day. So for example, cardiovascularly, our heart rate actually slows down as you get older. You lose some of those pacemaker cells, and you're actually not able to generate as much of a heart rate response to particularly aerobic activity. So that capability of achieving and maintaining a higher cardiac output for extreme exercise does go down. So that is a normal part of aging. How that affects us, or how that puts us at a higher risk of developing chronic illnesses, is that as we lose those pacemaker cells, there's other areas in the heart that say, hey, it's my turn. I'm going to take this up. And so they might jump in there with, putting a person at a higher risk of developing arrhythmias. The same thing, with the bones. The bones normally and naturally do get some demineralization as you get older. changes that occur with the hormones, both male hormones with testosterone as well as the female hormones with estrogen and progesterone change over time, and that affects the metabolism of bones. So that part is normal and does occur, but it still puts people at an increased risk of sustaining an injury or a fracture as they get older. And then we throw in things like osteoporosis where that process is accelerated, and that increases that risk as well. So we have those normal changes that occur that do increase the risk of developing chronic illnesses. And then on top of that, we may develop some of these geriatric syndromes. And they can really span the gamut. So things that are geriatric syndromes include incontinence, polypharmacy, falls. Incontinence can also lead to falls. And the point of this slide as we go through, functional decline is really to emphasize that a lot of these things are interrelated probably for all of us, but particularly for those at higher risk in our older adults. So something like functional decline, not getting up and moving around, can certainly increase our pain. And as we're having more pain, then we don't want to get up and move around, and our functional decline gets even worse. So lots of back and forth between all of these things. And they highlighted in blue are kind of some of the traditional things that we think of as being geriatric syndromes. So depression, falls, constipation, insomnia, caregiving concerns, functional decline, incontinence, pain, cognitive impairment, or dementia, polypharmacy are all things that we think about. So what is a comprehensive geriatric assessment? And that's really putting all of these pieces together. So it's a multidimensional, interdisciplinary diagnostic process to determine medical, psychological, and functional capabilities of an older adult to develop a coordinated and integrated plan for treatment and long-term follow-up. So that's a mouthful. And what it means is that we work together as an interprofessional team to look at the medical, functional, psychological, spiritual aspects, everything that goes into that concept of health, and really looking at it from that World Health Organization kind of concept of health, that big broad definition. We look not only for physicians or advanced practice providers with nurse practitioners, PAs, but your nurse, social work, pharmacists, therapists, physical, occupational, speech therapy, all have a role to play here. Definitely incorporating our mental and behavioral health practitioners. And most importantly, probably, is we want to make sure we're hearing the voice of our patients and our families or their caregivers as well. So we're going to walk through this first part of assessment, but then also some interventions that we might think of, and go through each of the different dimensions that we've already spoke of. And our comprehensive assessment really emphasizes not only the quality of life for the individual, but what is their functional status, what's their ability to continue to live as independently as possible for as long as possible. What is the prognosis for this individual? Certainly somebody who we are expecting a prognosis in 5, 10, 20 years of life expectancy has a different approach than somebody who maybe we are looking at their last weeks or months of life. And really taking into account all of this of what is that individual's goals and preferences. So for the medical piece, we're going to start by reviewing their diagnoses, talking through those. What is the control like, and how severe is it? And that's going through each of the different body systems and taking into account their cardiac or their pulmonary disorders. What is their neurologic status? Do they have cerebrovascular disease, or have they had a stroke? Do they have renal impairment or gastrointestinal issues? I'm going to definitely let my colleague Sue Fosnight discuss more here in just a moment regarding their medications. But we want to think not just their prescription medicines, but are they taking anything over the counter? What kind of vitamins and supplements? What kind of alternative health strategies is this person perhaps applying? What is their adherence to their treatment, and what are some of the barriers to that adherence, as well as their nutritional status? And things we might think of in that intervention. Is there something, as we're looking, is there something that's not lining up? Is there something we're missing? Is there a new diagnosis maybe that's related to some of the concerns that the person is presenting with? You know, what labs and imaging have they had? What referrals to specialists maybe do they need? More on the medications. How is their nutritional status? What are the barriers to these things? All right, so I'm going to pass this over to Sue, and I think I can let you drive here just a second. All right, you should be able to drive now, Sue.
Okay, thanks. Hopefully I can make the slides advance here, but I'll let you know if not. So really what I would be involved with from a pharmacy standpoint is a big part of what I do is assessing medications. And there is a method that is called the ARMOR method that is a general way that we assess medications. And yeah, it's not letting me advance, so
okay.
I'll just say next slide.
Perfect.
So the ARMOR is a mnemonic. I like mnemonics. Helps us remember things quickly. The A stands for really assessment. And when we're assessing medications for an older patients, we're looking at what medications they're on. We're also assessing for if they're having any side effects from the medications. And a lot of the side effects of medications would be basically some of the symptoms that they might be having. We can also assess for whether they're having any uncontrolled disease and assessing for their adherence. The R for the ARMOR, it stands for review, and we do review each medication for appropriateness, effectiveness, safety, and adherence, and evaluate the benefit versus risk of each of the medications. And that changes as patients really, as their disease advances, the benefit versus risk of medications may change as well. Okay, ready now. Thank you. For next slide. The M and the O stands for minimize and optimize. So I think we always would like our patients to be on less medications. So whenever possible, we're trying to use as few medications as we can, but then also to optimize, making sure that the symptoms are controlled, making sure that if a patient does have some benefit from a drug that's going to prolong their life, that we have that discussion about continuing those types of meds or starting those types of meds. And then our last part of ARMOR is to reassess. So when we do make changes to medications, especially in our older patients who are very prone to side effects of medications, that we always want to reassess and make sure that what we added, that they're not having any side effects to, or perhaps if we took something away, that they haven't started with new effects from not controlling a particular symptom. So that reassess point is very important. Next slide. So just to give you a little information about this, this is just a case that came up a few years ago. This is a fairly typical medication list, I think, for a lot of older patients that have several chronic diseases. You can see she's on a lot of medications. Next slide. So part of our assessment of the medications will definitely involve a history of the patient. We need to know the prior medical history, a little bit about social history, allergies. We always want to make sure our patients have their vaccinations so that we can prevent any of those type of complications for the patient. Next slide. And then a little bit about their symptoms that they're having. When we're working with a team, it's really nice that a lot of times these are collected for us. I'm looking in particular at the medications that they're taking and what are common side effects from those medications and making sure they're not having any of those types of symptoms. Next slide. Also looking at their vitals. Medications can affect blood pressure, pulse, so making sure they're not losing weight. Next slide. And then their labs. So again, the labs gives us some clues of whether a patient has medications that are causing side effects or whether we need to adjust those medications. Because as patients age, their kidneys in particular will not usually function as well as they did when they were younger, so doses may need to be adjusted. Next slide. So when we're looking at the medication list, one of the things, you saw the big list that I had listed before. One of the first things that we would want to do is to divide those medications into what they're being used for. And you can see this makes it a little bit easier to evaluate when you put them in their little categories. Next slide. And one of the things that I think when we're evaluating and trying to optimize medications, if we don't have good information to begin with, so we have a medication list that is not accurate, then we're not going to end up with being able to do the optimization. I know we say garbage in, garbage out, which means that we just aren't able to really do what we're trying to do here. Some of the things that get left off of medication lists very commonly are over-the-counter medications and herbal medications. Many of those can have some significant impact on our older patients, so we definitely need to know of those. Oftentimes patients won't include things they don't keep with their medication box. So inhalers, patches, and refrigerated medications are things that it's good to ask about, especially if they have a diagnosis that would make you think that they may need one of those. Next slide. So in our particular patient that I'm using as an example, we did do a medication history where we did ask about those things, and we found out that she was taking it, and I say she was with my students and I. When I say we, it was my students and I. We found out she was taking tiotropium. We found out she was taking insulin, which is refrigerated. The ibuprofen is an over-the-counter medication. The calcium citrate is an over-the-counter medication. Next slide. And then we want to screen for the geriatric syndromes if they haven't already been screened for. Oftentimes, side effects of medications will contribute to these geriatric syndromes. So these are the common things that we screen for: falls, pain, anxiety, depression, cognition issues, incontinence issues, insomnia issues. Very common things we see in our older patients, and also very common side effects. Some of them are for medications as well. Next slide. We also screen for medication adherence. I have a mnemonic that I use for this as well. It's called COST-B. C stands for cost. I ask some open-ended questions, and the particular question I ask isn't one that you have to use, but just something you're comfortable with asking patients about their cost of medications. I usually look at their medications, and if there's one that's expensive, I say, how do you manage to pay for your medications with this one that I know that is very expensive? Or just how do you manage to pay for your medications? Organization is how do they take the medication at the time that it's due? So what system do you use to manage your medications? Or how do you remember to take the medication when it's due is another question that I will ask. For side effects, what side effects are you having from your medication? For transportation, how do you get your prescriptions from the pharmacy? Benefit, I will ask which medications are helping you and which aren't. And then just to get an idea of how adherent they are to medications, I want to know how often they miss their medications. So I will ask how many times have you missed taking a medication within the last week to give me some ideas. And then there are some resources to assist patients, and I have those just listed out. Needy Meds helps to find patient assistance programs if cost is an issue. GoodRx helps also to find the medication cost that is maybe cheaper at one pharmacy versus another. Med Action Plan is a calendar system. And of course, using motivational interviewing can also help with adherence as well. Next slide. So back to our example, when we interviewed the patient, there were several things that we found out. This is just a list. It was just a partial list, the first page of what we found out. And talking with the patient and finding out the history of why they're taking their medications and how they're taking their medications helps us also to optimize the medications. And I believe we're on the last slide here. So this is after doing all this, I think we're now at the step where we really can minimize and optimize the medication. So we have a very clear view of why the patient's taking the medications and what we can do to help to optimize the regimen. So I think that's everything, and that's pretty much walked you through how we go about assessing a medication regimen. Now I'll turn it back over to Dr. Drost now.
Thank you. Yeah, and I think that that piece that you brought up about organizing the medications based on something that makes sense to you. Obviously, their indication is what makes the most sense to, I think, a lot of people. But you know, if it's by body system or something, just having a list of medications in front of you and trying to sort through it with no rhyme or reason is certainly a challenge. And one of the biggest banes and from the electronic medical record standpoint, there's no way to get those in a meaningful list other than alphabetical, which does still help a little bit.
I do agree.
So, okay, well, let's turn to Nancy for a few moments and actually kind of walk through a little bit of this medical assessment piece. See, you're on mute right now.
Hey, talk.
Oh, okay. I'm ready when you are.
Great, great. Well, Nancy, why don't you tell us about some of the challenges you've had with your health?
My biggest challenge, excuse me, right now and for the past, well, for quite a while, but it's really gotten severe this year, is I have glaucoma. And it's caused me to have very limited vision in my left eye. And I've had a really bad summer with the glaucoma. One point this summer, I use glaucoma medicine regularly, but one time this summer, my my glaucoma number in my good eye went up to 56. And the doctor really got concerned about that. And they changed my medications. And I did have some surgery on my eyes this summer, which I don't know. Well, the surgery caused me pain, but my eyes have just been so very painful that all summer that, and I'm very photosensitive. It has really had a negative impact on my life. I think one of the problems that it creates is I'm a caregiver for my husband, and that means I have to drive him to all of his medical appointments. And driving, for the most part, especially like on a day like today that's sunny, is actually a form of torture. My eyes just kill me, but there's nothing I can do about it. I wear dark glasses, and I do what I have to do. So, and of course, another problem with my vision is that I really have very poor depth perception, and I miss curves or changes in elevations. So I have to be very careful about walking. However, if there's no differentiation in the height of something, I won't see it. And I've taken some falls because of that. And the doctor, the medication that I was on for so long seemed to be working fine at controlling my glaucoma. When my right eye got so high, he changed the medications. And you were speaking of cost. The medications that he has me on right now, the cost, I asked the pharmacist about it. They cost $2,000 every time I get them filled. I don't have to pay that full $2,000, but it's kicked me into a level on my health insurance or drug insurance where I have to pay a pretty significant amount of money for my medications. I think that's probably about as much as I can tell you about that right now. Maybe you have some questions.
What do you, if anything, do you take for your pain at this point?
I'm not a good self-medicator. I usually just put up with it. I have drops called Relieve. I have found a lot of the drops that they give me to, well, I have extremely dry eye. And some of the medications that they've given me for that seem to irritate my eyes. And so I finally found this Relieve, which will relieve it somewhat. So I use that, and sometimes at night when it's just really bothering me, I will take one ibuprofen.
Okay. Well, it certainly sounds like the glaucoma and its effects on you is enough of a medical history. But just to run through a couple of questions, do you have high blood pressure or high cholesterol?
I take medication for the cholesterol, and it keeps it at a normal level.
Okay. And have you had a heart attack or a stroke in the past?
No.
No. And any history of cancer?
No.
Okay. And how do you think your memory is doing?
I'm always trying to keep track of that because that's really important to me. I have found myself making substitutions if I can't think of a word. I find myself thinking, okay, what's a word that could tell a person what I'm thinking? I can't give you an example right off the top of my head. And I don't know if that's part of me thinking, okay, something's going on here, so that makes me more anxious. And then that further, just like right now, if that further causes me to the anxiety of thinking, okay, what's wrong here, causes me further confusion about getting out the word that I want to say.
Are you sleeping okay?
Yes.
And we'll talk more kind of about mood and anxiety in a little bit. Eating all right, weight has been pretty stable.
I'm sorry, would you repeat that?
Are you eating okay?
Yes.
Okay. And has your weight been pretty stable?
I've probably lost 3 or 4 pounds over the summer.
Okay.
Which might be considered a lot because my normal weight is usually like 95.
All right. Thank you. We'll kind of keep moving here. Thank you for that. And we'll come back to some of those things here in a little bit. So we kind of got, medical history, talked about some of the, the control of Nancy's illnesses, particularly her glaucoma seems to be the one that's giving her the biggest trouble and causing the most potential for long-term effects. And then we move on to kind of the next section, which is a function, breaking them down kind of just basically into the ADLs and IADLs, lists again that you're probably familiar with at this point in time. And really can take that moment to just ask, Nancy, is there anybody or are you needing help getting in and out of the bath or getting yourself dressed these days?
No.
Okay. Any challenges getting to the toilet?
No.
Okay. All right. We talked about eating, seem to be doing okay. Grooming, again, dressing, bathing, and then, mobility. You did say that you've fallen a couple of times. A lot of it sounds related to your vision. Are you using a cane or a walker or anything to help with your stability?
No.
And then those IADLs. So we learned that Nancy is still driving. Do you have concerns about that, Nancy?
Yes, I do. I would not be driving if I didn't have to.
Okay. And related to your vision?
Yes.
How about doing your shopping?
No, other than reading labels and things like that, I have some difficulty with that. Sometimes I have to ask a fellow shopper, can you tell me what the price of this is, or something like that. Because there are some days when my eyes, I just have real problems with them. But as far as getting the groceries, no, I can do that.
And how about your meal preparation then? Are you managing that or getting some help?
No, I can do that.
Okay. Housekeeping?
I have someone come in every 2 weeks, but I can do it.
Okay. Me too. That housekeeper is certainly a blessing.
Yes.
And then any challenges operating the phone?
A telephone?
Yes.
No.
Okay. Are you using a smartphone or just a standard cell phone?
Well, I have a smartphone. I'm technologically, I consider myself the village idiot. So I could make it do what I wanted to do, but I guess there's a lot more that it could do that I don't know how to make it do.
Okay. And then right now, anybody helping with managing your medications?
No.
Okay. And anybody helping kind of keeping an eye on your finances? Paying the bills on time, managing those things. Okay. All right. This may also be a chance, and I won't do it here with Nancy, depending on the person that you're interviewing. This might also be the point in the conversation where you do, ask for some collaborative history from a family member or a caregiver, folks who do, even with or without cognitive impairment or some early dementia, some people, rightfully so, are very proud of what they've accomplished during their life, and maybe making some changes or some strategies to make it through areas that they're finding more challenging, that maybe they're not willing to share, but are important to know. For example, if taking medication management, so maybe they're taking them independently, but it is their daughter who's coming and actually setting up a pill box for them independently, or they're taking them independently, but maybe they're not driving, and the caregiver is only going to pick them up every 6 or 7 weeks instead of every 30 days as the prescription is noting. So trying to get a little bit more information from them. And things that we might do to assess, and some of these you can actually even do virtually and over the phone, is getting actually having the person stand up and walk around. This timed up and go, real simple, real quick. You ate up from the chair without using your arms, walk 10 feet across the room, turn around and come back and sit back down. If we have the camera positioned appropriately, even, you can really get, if I back up here a bit in my room, right? I mean, you can see me really well to know, am I having to use my hands? Am I having to rock to get up in order to stand? So those are things that you can appreciate pretty just even subjectively in the assessment. And certainly all kinds of things that we could talk about, ways to help kind of bolster people's functional ability to stay independent. How are those illnesses, again, those chronic medical illnesses, the medications, how might those be affecting their function? Always need to keep that in mind. Can we have our physical, occupational, or speech therapists in to do an assessment, to work on a home exercise program, to work on energy conserving ways of moving if somebody does have heart failure or COPD, looking at the home for a safety assessment, referring to social work to start thinking about, like, what are those next steps? Who else might need to be a part of this picture? What other durable medical equipment, DME, needs might the person have? Do they need a walker? Do they need a tub bench or shower chair to help with that? What are some of the community-based supports through the Area Agency on Aging, through Meals on Wheels, transportation services, perhaps that might be helpful for this individual? Grab bars and ramps, certainly keep those in mind. Footwear. As a geriatrician, they kind of really harp on us of making sure we're looking at people's feet, looking at people's shoes. And if you haven't had the luxury of taking off other people's socks and shoes and looking at their foot hygiene and care, it can certainly be an adventure. Talking about the financial management support, we definitely want people to remain as independent as they can for as long as they can. We don't want people taking over things just because they're worried that mom or dad may struggle with these things. But is there somebody keeping an eye on it? Is there a trusted financial advisor, bank, or loved one to participate in that? Again, the referral to home health. If we switch gears then and look at kind of the psychological and spiritual realm of things, this is where we start thinking about the mental and behavioral health aspects, your cognitive assessments, really that spirituality piece. What is that? And spirituality, right, is different than religion or being religious. And people can be one or both or neither, I suppose, though probably would argue that we're all spiritual beings. We all find meaning and value in our lives in different ways. So making sure we're keeping an eye on those things. Assessing fears. What is this person's, what are they worried about the most, not only in terms of their health, from a medical standpoint, but in terms of their ability to continue to live the way they want to live. And what are the community supports that are available for to kind of bolster, again, these things. So there are screening tools. Certainly conversation and interviewing is one way to do this. And this is not at all a comprehensive list of some of the screening tools that you might use. But the PHQ-2 or PHQ-9 is one of the most common ones. Real simple to ask, I suppose. So kind of harder for some people to grasp what you're meaning. So the screening tool is those two questions. And so run through them with Nancy. You know, in the last 2 weeks, have you been bothered by having little interest or pleasure in doing things?
No.
And then again, so the next step, if they did say yes, you try and quantify it. You know, is it every day? Is it most days? Is it some days or none of the days? So she said none. And then the second question on that screening is really in the past 2 weeks, have you felt sad, depressed, or hopeless?
Sad and depressed, but that's situational. I've really been very it's related to the election. I'm really seriously concerned about that. So there's been some sadness and depression over that, the way things were going.
Certainly a lot of stress and a lot of emotions that many people are feeling around the election, around life, COVID, everything else right now. So that certainly is a lot to keep on our plates.
And I think also it's just sort of I can't really say it's, and maybe you're going to ask me about this. I guess it's more an anxiety, just a chronic one regarding the state of my husband's health. You know, am I taking adequate care of him? And, you know, how is he going? How is his health going? And things like that. There's some, like I said, maybe you're going to ask me about anxiety later, but there's some anxiety tied to that.
Okay. Yep, anxiety. I didn't put that as a screening test on there. There's a Beck's anxiety screen, so there certainly are tools for that. But you know, if somebody who's acknowledging those anxiety feelings, then you certainly want to address those. So you know, conversation and interviewing and allowing people to have a safe space to let those feelings out might be the best thing that you can do for that person on this day. So not being afraid to you know, kind of lean into those. So you know, what do you do with those feelings when they start to kind of get the best of your mind and your heart on any given day, Nancy?
Well, during the summer and even up to some extent till now, I really love to work outside, and that's sort of a therapy for me to just get outside. I'm sort of dreading the bad weather that's coming. You know, I won't be able to get outside. I do have some plants in the house that I can take care of. And I walk.
Physical activity, nature, being outside, and gardening and taking care of something, right? So it sounds like you certainly are a caregiver through and through. So I'm sure seeing the kind of the fruits of your labor in that standpoint can be therapeutic.
Mm-hmm. And just physically doing it, you know, just, I love to dig in the dirt.
Yes. Yeah. Good there. Do you ever feel like your anxiety is kind of taking over?
I think that's situational too. And I would say it's more related to my husband, he's had a lot of serious issues, and he has chronic issues that, and quite frankly, I do have some anxiety about whether I'm going to be able to maintain my current living situation. I have anxiety about driving, about whether or not I'm going to lose my sight. Am I going to be able to remain living independently? Those things I have some anxiety about.
Those are all big worries. Who do you lean on to help provide you support?
I'm sorry?
Who do you lean on to help provide you support?
Not a lot. I tend not to do that.
And do you have a faith community that you're a part of?
Yes, I do. And, that's been a problem because we haven't met as a church since March. And, there hasn't been a lot of contact since then. And so, that's been a problem.
It's another loss.
Mm-hmm.
For sure. Thank you for sharing those things, and certainly some things that we might consider putting into place. Again, like we said, talking and listening, being that listening ear, being a safe space for someone to open up and to let some of those anxieties and fears out. Maybe working through and kind of bouncing ideas on how to navigate some of those challenges. Remembering that there are still medical concerns that might be driving feelings of depression and anxiety, confusion, any of those things that we need to make sure we're keeping an eye out for. Referring to specialists, social workers, mental and behavioral health, counseling, chaplains for some, spiritual counseling and support if available or if the person is so inclined. Encouraging, involvement of family or caregivers as that individual is allows, but certainly encouraging them to reach out. And assessing that capacity and ability to consent for treatments, identifying who that healthcare proxy is, would all be things that we could consider. And kind of tying in, it kind of ties like the psychological, really ties in a lot for a social assessment. Like, what are the social supports, the networks available for this person? Assessing the strengths and weaknesses in those networks. Right now, with COVID, that we mentioned church and having a faith community. That's for a lot of people right now is a big weakness in an established social network. That's not only the person doesn't have that connectedness, doesn't have that like support for it, but then also on top of that, you're compounding that really with a grief and a loss of those connections, and a lot of uncertainty about how and when those pieces might be able to be put back into place. Reviewing the life roles for the patient. So, we talked a little bit with Nancy about being a caregiver and about, seeing things grow and being in the dirt. And that's something that she's enjoyed. Right now, her health still allows her to do those types of things. But if one day in the future, her health became a barrier to doing that, again, another area where there's that, you know, potential for a loss of meaning and a loss of productivity, that sense of productivity in life. We also want to look at the financial resources, which we haven't really talked about. Housing stability, not only from the financial standpoint, but again, in Nancy's, as we've kind of talked about, you know, the ability because of the medical and the vision concerns to be able to continue to live independently. Assessing for food insecurity. So asking that question, you know, in the last 30 days, have you had difficulty getting food? Or have you ever gone without food? And then caregiver burden and assessment. So not only for the caregivers or the person you're talking to, but in this case, we're also talking to a person who is a caregiver. And what is the, you know, the burden of that? And I hesitate sometimes to use the word burden because it feels, right? I mean, things that we do willingly shouldn't be a burden, right? We should kind of pick up ourselves and do it. But, you know, things that are done incredibly lovingly and incredibly meaningful for individuals still is tough. I mean, it's hard work to be a caregiver. So recognizing those things. And then the cultural impacts, you know, and this may be, you know, somewhat apparent that there might be a cultural barrier between you and your patient or your client. And there might be other things that aren't apparent that needing to kind of dig into and ask those questions. So those might be things we think about. And some interventions. So I'm just going to go a little bit here just for the sake of time. Social workers are some of my best friends. So you have to keep in mind, they're great resources, again, involving family and caregivers, seeking out what those community or spiritual supports might be, looking for support groups, you know, for folks who are caring for loved ones who have dementia. The Alzheimer's Association might be a great resource. The area agencies on aging are wonderful resources. And then thinking about like Meals on Wheels, transportation services, again, those might be things that offload some of that, that stress and that caregiver burden. I also want to think about the environment. And again, the age of these virtual visits and stuff, that's actually wonderful at this point to actually be able to look inside the home. But this is also a place where we're relying on some of our, you know, community-based organizations who are physically going into the home, or home care agencies that are going into the home that might be able to provide some of that information back to you. So is it appropriate? Is it stable? Is it, you know, relatively, you know, safe and clean and healthy? Again, recognizing that people live very differently. So just because a house might be cluttered or might not be as tidy as I would choose to keep my home does not mean that it's not a safe or an appropriate home for an individual. You really have to kind of dig in there and think through some of those things. What's the transportation like? You know, person might not be driving any longer, and is there an availability for public transportation? Certainly in this area, there's not a lot of opportunity for public transportation, not without quite a feat and changes, bus changes, etc. Is the neighborhood safe? Again, Nancy said she likes to walk. Is it a safe neighborhood to walk in or not? And then telehealth options, as we've kind of discussed a little bit. Interventions, home safety assessment, modifications, getting physical or occupational therapy in the home, working with our community-based organizations, again, referring to social work, family caregivers, and those community-based organizations. And then advanced care planning should be part of this, and really starting to get, and advanced care planning, right, it's not a one and done type of thing. This really should be a conversation, and it should be a conversation that we all have, you know, with our patients or clients, kind of irregardless, or especially because of our different roles. You know, discussing the goals of care with that individual. And that doesn't mean you're going to walk away, you know, with a do not resuscitate order, or having had them pick a power of attorney. But starting to get an idea of what the values and the preferences are for their care, you know, to help to develop your treatment plan. I use this example, you know, I'm hugely motivated by food. And, you know, to me, not being able to eat, not being able to enjoy that time with family and friends over a shared meal is huge. And so if I were to have a stroke or have something happen that significantly limited my ability to eat, and that wasn't expected to recover, then that's something that I think my speech therapist and my team should know. So if the speech therapist is working with me and we're just not making progress off of pureed peas, that's something that I might be willing to take the risk of, eating a steak. So those types of things that really help us to navigate what the goals and stuff are. But it can be filling out those formal documents as well. A way I just like to have that conversation with folks. Nancy's given us a lot of insight, I think, today already, but really asking her, what is the biggest, well, she seems to have a good understanding. One of my questions is, what's your understanding of your current health situation and what worries you most about it? So she's really talked through a lot of those things. But then, if your vision does get worse, Nancy, what types of things have you thought about that you might need for your care?
Well, I think I'm going to have to relocate. At a minimum, our doctors, excuse me, are in Summit County, and we live in Stark County. And I know that there is, I think it's called SCAT, and that will take you to places within Summit County. So I do feel that that's something that I need to be aware of and, keep in the back of my mind. And I don't know if I would have to end up, in a assisted living or nursing home. That's certainly not, I don't think it's a goal for anyone, but I would not like to get to that place. And I think the biggest thing for me is I don't want to get to the place where I can't think.
And have you shared these worries or concerns with your family?
Yes, I have a power of attorney, that kind of stuff. And I've shared my feelings and thoughts with that person, and that person knows how I feel, that if I can't think, there's no quality of life there, and I'm not interested in just existing and not living.
And so obviously there's a lot more questions that a person could ask in this situation, but I think especially for maybe the first time you're meeting somebody or kind of getting all of these pieces together, and you may do parts of this over time, right? This is a comprehensive assessment, but that does not necessarily mean that it all has to be done in one fell swoop. But we've started that conversation with Nancy, and as different things arise, we can kind of pull those pieces out and say, you remember when we talked about this a while ago, this is what you had told me your worries were. Have those worries changed, or how do we align our treatment plan with that? Certainly, there may be things now that, if it were a risk of worsening her vision, then that's probably not something that, again, weighing the risks and benefits, and I don't have any specific examples off the top of my head, but we know that her vision is one of the most important things for her. So, you know, if there's a treatment option that has the risk of worsening her vision, that might not be something that she would opt to do, but certainly worth still that conversation with it. So as you can see, that's a lot to kind of think through and cover, and a lot that we've learned. Thank you very much for your time, Nancy. But what I'd like us to do then is kind of put together, we call it a problem list. So what are some of the big concerns that we have, or that Nancy has expressed that kind of fit in these buckets? And we should be able to, if you hover, turn it back on, oops. There we go. And turn the annotate on. And if you click somewhere in the box under one of those things, you should be able to go ahead and I'll pull up a text box, and you should be able to type in there. And then everybody can kind of see what folks are popping up in there. They're working.
I'm trying, and it's not working for me, but I had trouble getting controls before too. So. Looks like you can get a text box, but you can't type in it. At least that's what I'm having problems.
Okay. So I want folks unmute and shout out a couple of things here. Ooh, I do know. Oh, we even practiced.
Well, I'll start. I think loss of vision is certainly something that is a huge medical concern.
Okay.
I think the lack of independence is weighing heavily on Nancy. Having the eye issue, not feeling comfortable with that. I think that could lend to a lot of other things, including depression, that might affect the quality of life.
I would even say she talked a lot about some of the external stress from things like the election. So that would probably tie into environmental things, kind of another loss of control over that. It's something that she hears about and something that's really stressing her out, and rightfully so. So I would definitely cite that too.
I may be extrapolating here, but probably some caregiver stress too. I mean, she touched on it, but we didn't delve a whole lot into it. I think that probably plays into it.
Great.
She kind of said that she doesn't really try to rely on anybody else as far as social supports go.
Right. To some extent, it does. You know, does it? You know, we could ask more questions. Is that kind of that self-imposed limited social stressors, right, or supports, not wanting to burden other people, or worried about or other people's, you know, schedule, those sorts of things? Or is it, you know, for some people they don't have those supports, for other times it's that not wanting to ask for help, not wanting to burden others, wanting to save it for when I need it most. Those might be things that people might express.
And that's kind of what I got from her, that she's fiercely independent. I can do this myself until I really need, until I really need it. I don't want to burden anyone. That was just my read from listening to her.
If I remember correctly from earlier on in the conversation, she says that she has stumbled or fallen a few times. She says that it has to do with her vision, but there could be other things going on that are adding to that.
I would like to say loss of control, which I think is a tad bit different than lack of independence. I mean, she's talking about having to move, having to maybe not drive, not like needing help when she's doing groceries. So maybe I think it's a combination of independence and control, but there's slightly different. I think also affordability, right? You mentioned, I think I'm going to lose everything I have with the expenses, with the medications and other things.
Signs. She did mention specifically the cost of.
She says she has to drive out of necessity, but it sounds like she, recognizes the safety issues of it.
I would say too, another thing is, she mentioned that she knows that she's likely going to have to move, mostly because of the driving thing, like being closer to scat drivers and such. Obviously, that is another loss of control. That's another stressor. And just realizing that and knowing that that's kind of imminent and in the future, that would be really difficult, especially for someone who's a caregiver, someone who's on the more independent side normally, and just kind of some of the safety concerns that could present as well.
I just want to ask a follow-up question. I don't know if you're going to address this maybe in the future sessions, but when some of these issues come up and you can't do anything about it, for example, cost of medicines. Let's say you're the ophthalmologist prescribing these medicines, but that's the only option. How do you deal with it?
So, I can start that conversation. This is Sue Fosnight. So from a pharmacist standpoint, a lot of patients that are on Medicare will qualify for some patient assistance. And some of these medications, the newer ones that are very expensive, will start that at a lower income than you would think. So when it gets to the point that you're in that Medicare Part D gap, many people will qualify. So just making sure that you use the tools. I use needymeds.com a lot to see that. But you are right, there are some times when there aren't a lot of options. So usually at that point, we're looking at the other medications as well. Can we get any of the other medications a little bit cheaper or those paid for? So trying to do the best we can to minimize the cost to the patient. It's surprising how much is available through these patient assistance programs if you look hard enough.
Could I respond to that?
Sure.
Please.
Sue, there is some people, and we are included, where you make too much money to qualify for assistance, but you don't make enough money to be putting out $500 a month or whatever in pharmacy costs. So, there's a gap in that.
Absolutely. And there are groups, there are patients that you might fall into that. If you have a decent pension, then sometimes you're not going to qualify for those programs. But it's worth a try. I always feel like it's worth a try because there's some of them that are really fairly high incomes, and some of them that have like rebate programs that have nothing to do with income. So it's worth looking.
Well, Sue, if you know of anything like that,
I
is
will
there any,
I'll talk with you offline, or I'll talk with your daughter, Sue. And
yeah, why don't you tell Sue? And
yeah,
then
I'll be happy to look into it for you. Definitely.
all right, thank you very much,
You're
Sue.
welcome.
And while I'm talking, I just want to say hi to Denise. Hi, Denise.
Hello.
Nice to
Nice
see
seeing you.
Okay.
I have a question for Nancy.
Mhm.
Nancy, how comfortable are you in using the internet and electronics?
Like I said, I consider myself the village idiot when it comes to technology. I piddle around with it, but I don't feel very competent about it. I'm forever having to have one of my grandchildren come over and bail me out. I'll use it when I really feel like I have to use it, but it's not my favorite thing to use.
Thank you. Because my point is, I think that's an issue with active older adults, or even those who are having conditions that, you know, so much of our life has gone online, and
Right.
this population is really struggling with that.
We are. I know for myself, I was a teacher, and there's absolutely no way I would go into a classroom today, because a first grader probably would have to tell me, well, you need to do this and you need to do that, because, you know, you are probably the first generation that really got proficient at computers, where for myself, they were just coming in. And right before I retired, there was some computer programs in the classrooms, but very, very limited. And tell you the truth, I don't even remember there was the internet. So you're right. And I think that's something that would be helpful for your generation to know, that we are not and I'm not just trying to, you know, make myself be the model for everyone, but the ones that I talk to, I think we generally feel that way, that we are not as proficient. We could be, but I think, you know, my first reaction when I want to know something is I want to get a book. And my son gets out his phone, and, you know, in 30 seconds he has the answer to the question. So we are of a different mindset, I guess. You know, we look for the ways we were familiar with for information, not the internet.
I think that's very true in my interactions, you know, with older adults. But I think that's key that you said is we could be, right, and not as an obligation or an expectation that you jump into that, but to make sure we're asking, we're trying to facilitate, we're you know, supporting people who are trying to learn this technology, you know, for the first time. You know, as much as that they're willing. Again, not as the expectation of you need to learn this, you should learn this, I expect you to learn this. But if this is something that you find valuable, how can we help you to use this better? So that, right, you can still, older adults are still very capable of learning things. That's for our students.
But our interest isn't there. I have found that. I'm sorry to interrupt, but my Sue needs to take, speaking of my technological illiteracy. I'm using Sue's computer, and she has to take it for her next meeting. I just want to tell you, in reading your assessments, I feel like you were very perceptive because I think you were able to understand in just reading these issues that you have put. I thought, boy, they're on to me. I think you were very perceptive in drawing conclusions from what I shared. And thank you for listening to me.
Thank you so much for your time. We very much appreciate it.
You're welcome.
And bye.
Oh, bye-bye.
Bye. All right. Just to wrap up, so kind of an example, a little bit of kind of what a geriatric assessment is. Are there any other questions or concerns? Any other points that you thought of that you want to highlight?
Dr. Drost, how long does that take you?
I mean, so this, if you do this all at once, it's probably, 45 minutes to an hour. It depends on how complicated the, individual is. From a medical standpoint, Nancy is actually really straightforward. She doesn't have a lot of, comorbidities and a lot of chronic illnesses. So to sort through somebody's medical history sometimes can take, quite a bit of that time, and then to pull these other pieces out. What I probably haven't emphasized quite enough really is the interprofessional aspect of it. So when we do these in the office, right, it's not only the physician or nurse practitioner, APP, ours are mostly NPs, but we also have a social worker there who's getting a lot of the the functional history, the environmental, assessing the social supports while we focus on the medical piece. We also have like our our MAs and stuff in the office that get some more of those historical pieces. So those are already available and in the chart. Ideally, we also have, Sue is our pharmacist. She doesn't necessarily sit with us on every patient, but she's a great resource for us to have if we do have concerns about medication interactions and stuff. I would love for her to be there for part of the team, but lots of billing and financing of medicine put barriers in place for that. It would be lovely to have, or it would be wonderful to have, physical or occupational therapy person there with us to, assess gait, to be able to kind of start a treatment regimen or say, yeah, this person really would benefit from, physical therapy. Whereas I think this person's probably, at their baseline and might not benefit as much. I think all of those would be, great to also be there.
Yeah, I think as probably a physician who may not have all of these resources, it would be really insightful to know, how do you split it up, right? Like if you have to split it up, if you cannot do the 45 minutes or an hour at the time, it's really important to do all of these pieces. And if you do not have all the support stuff, how maybe would be a good place to split things up.
I think that there's, there are a lot of ways that much of this information, could be gathered in writing, in a survey type of thing. It's not as good by any means as hearing it from the persons and hearing their story behind it. Part of that is because I think that's an incredibly therapeutic process for not only the patient, but helps to build those bonds and is meaningful and valuable like in your work as well. But getting some of the nuts and bolts out of there, there are validated tools to assess ADLs and IADLs, that people can fill those things out themselves. Something like the PHQ is actually designed to be self-administered, right? You give the person the test and they fill it out. There are other assessments that are much like that. So I think there are ways that you can pull some of those pieces out differently, so that it's not, you as a physician, particularly like in primary care where you have your 20 minutes maybe to see the person. And then the other thing is particularly with complex older adults, you know, as much as you can in the scheduling, also recognizing like this isn't something that all has to be done at once. You know, that we might pull out parts here and we might come back and talk about this other piece, you know, at your next visit.
And I have a follow-up, probably something completely separate, and maybe you'll be addressing that in the future lectures, about, she mentioned both dementia and driving issues, formal assessments for those and resources for that in the community.
Yeah, so there are multiple screening tools that can be employed. Most of them take 5 to 10 minutes. You know, real simple in a primary care office, a mini cog, which takes probably about 3 minutes, sometimes 5 minutes. So a 3-item recall, so you give the person 3 words. You know, apple, table, penny are common ones that are used. You ask them to draw a clock, so it's that circle, put all the numbers in 1 through 12, and then ask them to put a time on there. 10 past 11 is one of the common ones. 2:35 is also, you kind of want it to have hands on both sides of the clock so you can see if they're able to differentiate between the two. And then also some kind of like number trick. So saying it at 10 past 11, right, are they going to draw the minute hand on the 10, like the 10, or on the 2 to represent the 10? So that little bit of a number twist. 2:35 is also one, so you're getting hands on both sides of the clock. But a lot of people, particularly who have, you know, even early cognitive issues, will draw a hand to the 2, and then also 1 to the 3 and 1 to the 5. So you're getting those kind of numbers in there a little bit, which is looking a lot of the executive function, the planning piece, and then you ask them for those 3 words back. Mini cog, if you miss 2 of the words on the recall, it's in, you know, it's a positive screen, so it's a flag that there's something wrong here. Or if the clock looks, you know, wonky, then that's also a positive screen. Or you missed 1 word and your clock doesn't look quite right. Those would all be things that, you know, in a primary care setting, you could easily employ pretty readily. And those resources are also available online. If you look up MiniCog, there's you know, sheets that you could be printed that have you know, kind of pre-formed on there.
So the test positive, what's the follow-up?
So from there, you could either do more assessment in your office, or at that point, I would say referrals either to geriatrics, neurology, or to neuropsych testing, so that the more advanced testing could be done. A lot of the neuropsychiatrists or psychologists that do clinical work, though, are associated with either neurology, behavioral health, or geriatric offices. So a lot of places probably have to go through that front door anyway.
Thank you.
And then driving wise, so there are some specific occupational therapists that will do, as an IADL assessment, do a driving assessment that's looking at hand-eye coordination. Some of them are actually do have simulations, but not all of them. There are places that will do on the road testing. Acute rehab hospital, so Edwin Shaw had one. There's one down, I think Mercy Medical in Canton has one, and then there's a guy called Wally who has his own business where he's doing these. And if it comes down to it, you can you write a letter to the BMV, particularly if you have like real concerns that this person really shouldn't be driving. You can write a letter to the BMV and request them to do an on-the-road driving test for people. I think that's one of those misconceptions, right? Once you have your driver's license, there's nothing you ever have to do to keep it other than to continue to renew it. You know, there's not a cognitive test of rules and regulations. There's not a driving test that you like ever have to do if you stay like in the same state. There are a few states that they require at different ages that you have to have another assessment done. But in Ohio, there's not. Other questions? And definitely, if there's questions or anything I can help with, don't hesitate to reach out. Happy to be a resource for you.
Well, I just want to thank everyone. I want to thank Dr. Drost and Sue Fosnight, and particularly Nancy Brown. I want to thank you all for a great presentation. And I want to thank the attendees for their participation. And we will, since we are just about at our time, we will say adieu and see you soon.